All right, well, good afternoon, all. We do appreciate your time to come into our session today. We have two great panelists with us today, and fresh off from some of the great and interesting topics at the HealthTech event. I think they've got some great insights as to some of the things that have been discussed and shared, and some ideas have been, that there's more to learn from that. I do want to say two things before we start. This session is being recorded, so for those that are joining us, or for those that can join us, you should be able to view the recording. At the end of it, we'll post a link to you guys. And then second, there is a Q&A. There's a Q&A feature on the viewing side, so you guys should be able to click on the Q&A and post questions. And what we'll do, we'll handle most of the questions towards the tail end of the presentation. But in the event there's some questions that tie into a specific slide, we may just interject the panelists and bring those questions at that time. But nonetheless, we want to make this as interactive as we can. So between Anne and Don, we'll make sure that's interactive. And then between you guys, feel free to pose any questions. So without ado, let me introduce the two panelists here. And if you can move to the next slide, Anne. Okay. So let me introduce Anne. Anne is the managing director of HealthTech Capital. She's been doing this for the last 25 years and have grown many companies from startup to being a CEO herself as well. One thing that Anne and I may have a place in common, which she doesn't know, is that she actually lives in Brussels, and I lived in Brussels for 3.5 years as well. Probably we didn't meet at the same time.
I was born in Brussels.
Born in Brussels, excellent. So actually I lived there for 3.5 years. I really liked it. Amazing food. And beer, for those that enjoy beer.
Well, that's why there's nobody in Belgium that's lean and mean. We're all nice and soft and round.
That's right. And then let me introduce Don as well. Don is the managing director at HealthTech Capital as well. Don has been in this industry for quite some time. He has been helping startups, been mentors, and have written books that have been used in education as well. Okay, and Don and I had a previous webinar here, and the feedback was just amazing to the insights and the information that Don has provided. Okay, so
thank you, Nick.
Let me pass this on to Anne, and she will take this on. Okay.
Thank you so much. I mean, we're really excited to share the information, Don and I, about what the conference was. For people who attended, these are some of the things we're going to cover today. And for people who are not there, these are going to be some of the summary key takeaway of the conference. So we're going to do a quick review of what happened at the conference. And a lot of people have asked for some of the summary slides of my keynote. So I'll probably spend 15 minutes, kind of going for some of the big takeaway. Don will kind of review the competition awards. And then we're going to do a top 10 between the two of us. What were the key lessons and surprise that we got from the conference, and then we'll open up for Q&A. So that's what we're going to do in the next 60 minutes. So please, another ride. I think it should be a lot of fun. And Don, do you have any comments?
No, I think that's a great summary. I think I just make a quick mention that in co-founding HealthTech Capital with Anne, that's been a tremendous experience. We started in 2010, and we have a wonderful ecosystem of providers and investors and angel members, VC members, as well as industry members. And so it really allows us to bring a unique perspective to bear on the health tech space, because we really have all the players under one tent.
Yeah, and one of the reasons why we started a conference 3 years ago, this is our third year, is because we really wanted to put together in the same room the entrepreneurs, the large corporation, the investors, and the providers and the payers. And I think this year we accomplished this. These are some of the key panels that came out on the 15th, which was our main day, which is talking about the accountable care organization. We're going to spend more time on that. Where were the unmet needs of the providers? Why don't we ask the customers where their needs are? And we did that with the private exchange, the employers, and the payers. So we really got that constituency to express where the needs are. We also asked the lessons from the people who have done it several times. And we had an amazing panels of people who have built very significant company in this space. And then we had a question about how are we going to do healthcare anywhere? That's kind of the big goal of the industry. So we sold out with 460 attendees and 47 exhibitors. And this year we doubled the amount of speakers. from 25 the prior year to 51 this year, and we've been blessed to really being able to attract some of the best thought leaders in the industry. And as you can see by the attendees, we really work really hard to try to get all the constituents in the same locations. So let me kind of take away some of my keynotes. I'm not going to go for the whole keynotes for people who have seen it. I just want to reemphasize what were some of the key points. First, there are really three tectonic disruptions happening in the industry. I mean, clearly there's a consolidation of the system, and we're going to talk about the fact it's a messy transformation. But the biggest takeaway is that there's a change of the at-risk alignment, and that is going to be driving new business models, which will impact people selling to this healthcare system. The big takeaway also that came up was that initially people really want to focus on operating efficiency because they're still under fee-for-services and a hybrid, a value-based payment system. And then over time, we're going to more have some needs for, but also for clinical, and ultimately what we're all looking for, personalized healthcare. The other big change that Don is also going to be bringing up later on is that there is a massive shift of the risk going from the employers to the providers to the patients. And that's opening up some opportunities for employee tools that are being provided to the consumers to manage their care. And the third one is really the dramatic force is that we are trying to consumerize healthcare. And part of that is making the data available, transparent, but also make it actionable. So it has to be data knowledge, which will enable the consumer to take control of their health. And we're going to cover some of these points in more details. So where are we coming from? Well, we come from an at-risk system where most of the risk was really borne by the employers and the Medicare, Medicaid, which is part of the government system, paying for people over the age of 65 or have a low level of income. And this money was really going to the health plan, and the health plan were really the gatekeepers. And then they were really working with a physician. It's a physician-centric system where if you had a problem, you were going to where the physician was, and you had the silos between the hospitals, the acute care, as well as long-term care and home health agency. They were all kind of into a volume-driven system there, where at the end of the day, the patient was just a billable event. And so the problem of the system is that it was really focusing into a volume where everybody was maximizing the transactions, and it was really reactive, to somebody being sick and having an event. We're trying to turn the industry upside down. So as we've just discussed, it was really an industry that was driven by the payers and where the hospitals were kind of managing on a B2B type of business transaction. And we're trying to really focusing into a new type of system where we focus on the patient across the continuum of care, wherever they're sick or healthy. And we're going to see that the role of the primary care physician is going to change drastically in this environment there, where they're going to be really the one driving the relationship with the patients, and therefore the relationship when there's an event with the hospitals and the specialists. And as you can see, the payers is at the bottom of the pyramid, and one of the big changes in the industry right now is the Aetna, the Blue Shield. We're trying to reinvent business models. So what will that world look like if we get there without too many bumps on the road? Is that there's the role of the public and the private exchange, which are going to really enable the patients to be in charge of picking the type of plan they're looking for. But come with that the fact they're going to be at higher risk. And the higher risk is kind of the deductible, and the health savings accounts is now a very big part of the system there, and can be as high as $65,000 to $700,000 per person in the family there. The copay have gone up drastically, up to 30 to maybe 40% of a visit or a hospital transactions there. So as a result of that, there has been a consolidation of the industry, and the hope is that we could provide a comprehensive and coordinated performance where there's an alignment between all the providers in taking care of that patient family there. It does beg some question, with that new structure, what will it do to the business models of the traditional pharma and medical device companies as they're selling their products to these new entities? The hope is that we're going to move towards a proactive care where the patient is going to be at risk and therefore be much more centric to the healthcare delivery system. One of the ways we're going to get there is by using big data. And data by itself has no meaning. It has to become an actionable insight. And the question is that, well, what is data? And data is not really created equal. There's, for example, a constant parameter, which is, you're male or female. There is the stable data, which is a color of the hair, of food that's changing over time, unfortunately. There's the dynamic data, which is really what a lot of people are focusing. That's in the EMR, which is your blood pressure, your vital signs. But there's really two other type of data that we're not really capturing right now, which is really driving the consumer behavior. And Georgian Schlane from Health Loop brought up the concept of the U data, which is who are you? What drives you? All the qualitative information, your anxiety, your fears. I added to it what I call the E data, which is the environment data. If you're asthmatic and then there's some condition on weather that will affect you, the lifestyle that you live, your family and your support, will affect it too. So what we are hoping is to drive a consumer shopping revolution. If you look at other industries, what we have done is that, will it be in mobility or shopping, is that when the consumer gets to be in a position there where they have availability of data, they can compare solutions, they can do crowdsourcing on information on each other. They have information on themselves, what I call the me data, which is the quantified self. And hopefully we're going to figure out how to do the connectivity of the electronic medical record or the health records there. What is going to happen is going to drive more competition and innovation. So for example, one of the things that people are talking about is to provide health surveillance as a services. Other people have been very successful in providing health coaching, let's say post-discharge of hospitals, and ultimately develop what's called personalized medicine. That will drive a lot of new technology like quantified self, disease monitoring, telemedicine, at home, clinical trials in a totally different way that's been done today. And of course, the use of genomic data. It does explains why, as we're moving towards a more consumer-centric there, that we see a lot of really companies who know how to sell to the consumer, who historically have been disruptors of industries, like Apple and Google, coming into the space and then developing products or platforms to enable the consumer to manage their health. Two major players are also people in the drug chain industry, which is Walmart and Walgreens are aggressively, trying to go after a modification of the primary care provider model. And in their mind, 65 to 70% of Americans live within 3 miles of their stores. So why do you have to walk to a hospital or a clinic there if you're already shopping in the mall? And so there's some very interesting concepts that are being explored and implemented right now by these two leaders. So one of the big problem or opportunity right now is that everybody's trying to figure out how we're going to get there, how we're going to get to patient-centric there. So what we see is on the hospital side, there is a consolidation of the industry where the hospitals are buying each other up and then aligning themselves to usually tertiary care centers. And in the process of that, they're buying physicians' practice. It's estimated up to 50 to 70% of physicians by the end of the year are going to be working as employees for some of these entities. And there's already 200 hospital-sponsored health plans, so they are providing health plan to employees or directly to the consumer. As a response to that, which is really moving towards more the Kaiser or the Geisinger models, we have also seen the physicians responding to it by doing their own merger, creating this very large physician practice, negotiating directly with the payers, the employers. Like, for example, in the state of Florida, one group has up to 20% of the baby born in Florida, and then negotiating back as they get paid for the full delivery of the baby there, negotiating back with the hospitals a fee for using the hospital. So we have a lot of the change in the flow of the money happening right now. The health plan themselves, since the business model is changing, are in the middle of doing acquisition. And they've acquired hospitals, they've acquired physicians, they've also provide more like a retail medicine insurance plan. And so we have a lot of experimentation going on right now in the industry. At the end of the day, the goal is to be able to move from a B2B, which is in the past we were negotiating contract with the employers, to really providing more into a direct-to-consumer approach in the industry. One of the challenges that the providers are facing is how they're going to go for that transition. Right now, depending on the hospitals, between 20 to 80% of the revenues are still fee for services. What it meant is that in the past, it was very predictable. You had a certain increase in your revenue that was happening there. The challenge is, as we're moving towards these new models, by definition, as they're providing guaranteed savings and reduced rate, the revenue is going to go down. If we are successful in treating people anywhere, that means the utilization of the hospital settings are also going down. So the challenge is, is how do you manage that transition? The objective is to do a transition towards accountable care organization, bundled payment, shared savings. There's a lot of different models right now. And I think the consensus that we heard from some of our experts and panelists is that initially what works for everybody as you're having these dual models is to really focus on application and product and services that are going to improve operational efficiency there and therefore decrease cost. As we're moving more and more towards the value-based models there, one of the big issue is like the airline industry faced it. How am I going to manage my fixed costs? How do I manage my capacity as we're taking care of people, let's say, outside the hospital? So there's going to be a lot of issues in managing those resources. Care coordination will probably require new care delivery models as we're managing people from the home all the way to the ER and the ICU. And there was a feedback from some of our panels that, really changing clinical variability, which could be as high as 2x, as been shown by the Dartmouth Atlas report, is going to be one of the biggest challenges there in being able to do real-time analysis of data and push it directly at the point of care at the time of intervention with the patient. And that will, of course, lead us to what everybody's hoping, which is proactive population management, which is to identify people ahead of time about how we can help them change behavior before they have an acute event. So another major area that's being disrupted, as I mentioned earlier, is the primary care business. Clearly, the retail pharmacy are building up their own clinic stores. They have some of the largest infusion centers in the country there. But there is a new model coming up called the primary care medical home. And the concept of this one, and there's a lot of really big projects going on right now, is that the primary care providers is really managing the patient. They usually surround themselves with health coach that communicate with the patient on a regular basis. And the objective is to decrease the utilization of the expensive part of healthcare, which is a physician specialist, the ER, and hospital admissions. A lot of those have business models that provide guaranteed savings to, for example, an accountable care organization or a payer, up to a flat fee payment, which is more like the Kaiser model. So this leads to new business models. In the past, we used to sell a product. And one of the problems of selling to healthcare, as we all know, is that it's a very long selling cycle. You need a lot of data. If you see a data that's a different type of hospital settings, you may not believe it's right. So it has been really hard to sell to the payers and the provider historically. What has been interesting is changing the relationship between people developing products and the payers and the providers. And we're really moving towards more into a partnership. And by that, it could be from a collaboration, developing a product together, to a joint venture. There are several of leading academic institutions who are expecting equity for doing a pilot with some of these startups because they believe they're enabling those companies there, and they see it as a co-development partnerships. Some of them expect guaranteed savings. I don't want to pay for softwares and just wait for 2 years to see if I have any return. I want some type of guarantee of what my cost savings is going to be. Other ones are coming out with payment based on achieved metrics. One of the issue is that it does create some conflict in the culture between the for-profit entrepreneurs, which are very aggressive, fast-moving, and the non-profit provider culture, with a lot of them having religious organizations involved. And there's some kind of alignment there that's going to be interesting to see in the next couple of years. So what it means is that as we're improving the data granularity, where it used to be in the past, we will go from a population there with different type of individuals and different type of disease to, let's say, go to a disease-specific subgroup, let's say diabetes, to an episode of care, which is somebody who had orthopedic hip implant replacement there, and then at that time, before surgery to post-rehab. We're now moving to we're starting to have the capability to look at the individual level and of somebody and the performance of an intervention for that specific individual. It does raise some interesting question on privacy that hasn't been fully resolved yet. As we have the capability of being much more granular with our data, it has allowed some very creative entrepreneurs to go from the traditional per member per month payment, which is what you pay for aggregated unidentified population, to really start going to a disease level, let's say diabetic management, where it's a certain price and maybe you share the savings between the payer and the providers and the person providing the services, to now we're seeing a company like Accolade who is providing guaranteed savings. Give me your patient after the hip surgery and I'll take care of the whole rehab afterwards. And then to the level of you only pay me when there's a successful intervention. For example, Omada Health came up with a concept that if the patient loses 5% of their body weight within a certain amount of weeks, they'll get paid their full fee. And that's at the individual level. So we see a kind of a change of the alignment. One of the big questions we had as investors and entrepreneurs is that, is there lessons to be learned from people who have done digital companies in the past that have had a huge exit? And we call them the unicorns. The unicorns are companies that have been started and had what's called a $1 billion exit, which could be an acquisition or an IPO. And of course, it's kind of sobering to see the odds. It's less than 0.07%. The good news, there's 4 born per year, which of course every investor is chasing. It does take 7 years from start to finish. It is interesting that there is more direct to consumer than B2B companies, but the value of the B2B is higher. So it does take a little bit longer to maybe realize the value of a B2B there, but you have bigger exit. This is for me the interesting part, is that the team, 90% of the team had worked with each other before. I'm going to move my camera because it's right in front of me. And the founders were over 34 years old, so they had done companies before. 80% of the founder, at least 1% on the person on the team, had at least done a company, prior, and they had worked with some of these other team members. And then the good news is that the CEO who was the founder at the exit, as the CEO who was at the exit was in 76% of the time the original founder. And this is important. Those companies did not pivot 90% of the time. In other words, they just focused and they just executed. So will that happen in health tech? I think there's a lot of lessons to be learned from what happened in the traditional software, digital industries. And I'd just like now to move on to our competition awards. Don?
Yeah, thank you, Anne. I've never seen anyone other than you do such a great, concise summary of the industry. So if I have the next slide, please. So with the venture competition, what we had is that we had exhibitors that submitted their materials and executive summaries to the venture judges. The venture judges reviewed all of these materials. We had tier 1 people on the venture panel, and then also they would walk around and talk to the companies prior to the panel. We had 3 finalists that presented on stage that have really interesting businesses. Frame Health has the proposition that not one size fits all. That when you're trying to do instructions for patients and what it is that they should be doing, that there's real differences in different personalities. One might be very concrete, have a very scientific approach, and the communications for that person might be very different from someone who has a very qualitative, warm and fuzzy approach. iHuman Patients is a really remarkable 3D, what they're calling kind of a flight simulator of the human body that's used in education, both in medical schools and also for helping with clinicians and new procedures. And then Vitrios Health is really an application of data analytics and really identifying high-risk patients who need more focused and more extensive interventions in order to improve outcomes. And so amongst these, next.
Oh, it's fighting me.
There we go. So the winner was Vitrios Health, and Vitrios actually was a finalist at the 2013 convention. And so they found that there was great value there, came back in 2014 and took the prize. And so, and they are, as I was mentioning, they're using predictive analytics to improve outcomes and reduce costs on a population health basis. Then we also had another competition, which was the audience vote, the people's choice. It's always interesting to see how what the audience is looking at compared to what the venture judges are looking at. And with Excel Diagnostics is an at-home diagnostics for chronic disease conditions. And so they're starting with, it's kind of like the cholesterol test. It's a finger prick. And they're initially addressing congestive heart failure with the goal of reducing hospital readmissions.
So this is not the fun part. We'll do the back and forth between Don and I, and Don draw the first one.
Okay, well, so the first one is we'll talk a little bit about money. That's always a popular topic. And so this really came out of one of the workshops that was on the 14th, the day before the main conference. And what really came out of there is that there's really a lot of options now that just weren't available 5 years ago. And the other thing, it's important just take a moment and make a distinction between investments and loans. So really with investments, you're taking team risk, market risk, product risk at different levels, execution risk. Really with lending, it's really a kind of a time shifting of money, if you will. Accounts receivables is a classic example where the work's already been done, the bills have been sent out, you're waiting for the money to come in, and the only risk is bill collection, and the bank is accelerating the receipt of those funds, and they take a fee for that. But now that same time shifting is going on, but they're really moving into new areas, and they have models where somehow they've been able to work it out with the regulators, but they have programs for, say, pre-revenue companies. That didn't exist before. Now, the kind of situation for that is where there's probably a big contract with, say, Merck or someone, and there's some particular milestones. And so, again, they're highly confident that the money is going to be coming in, but there's flexibilities there that didn't exist before. Similarly, SaaS companies were unfundable traditionally, and in terms of loans, and because they don't really have accounts receivables, they're really delivering the services as soon as they're collecting the money. So that left them in a hole there, and now there's a lot of options there. Same thing, things are loosening up on with venture debt options as well. And really the key issue is building relationships in banking, and to start early on that, because it is a trust relationship. And I'll just make a small note too, is that there's also a lot of loans, and for startup companies are also starting at lower amounts than what they used to be. I mean, and like, you don't have to borrow $1 million to make it worth it to the bank. There's some programs that are down in the 100 to 200,000 area. Square One Bank, for example, has a program that they call Square Roots that is specifically targeted to startups.
So is there certain bank types that, is Citibank doing this, or this is more the local, small regional ones?
Yeah, well, that itty-bitty bank, Citibank, that's nationwide, this is not the sort of thing that they can do. So really, around Silicon Valley here, there's Square One Bank, Bridge Bank, Silicon Valley Bank are big ones in the space. I'm missing one, which I'm embarrassed about, but because there's 4 big ones here, and Comerica certainly has programs too in this area. So there's options, and so the big thing is that there's new options out there in the marketplace. So it really behooves you to go out and become familiar with them.
Great, well, thank you. That was very interesting. So on my side, how do we scale up after you get all this fantastic money from the bank? And a couple of things came up. We had a panel on how do you build a team, and as well as the lessons learned from the stars. And it was very important to say that really the role of the CEO in creating the right culture and building the right team was essential. In fact, some of the investors says that they will not invest in the company unless that person has that potential. The recruiter basically says, really the best way to get this right is to hire slowly and fire quickly. When you know you have a problem, don't procrastinate, but don't fall in love with the first person you like, because you may end up regretting it afterwards. We had some of our star panelists says, this is a long journey there. Learn from every mishaps. It will happen a lot, and celebrate the small wins with the team is really important in building that culture. And Brian Roberts, I asked him, I said, what would you like to ask this star panels? And he says, always focus on what's over the next hill. As you're working on this big problem right now with your team, you as a leader, you have to really know where you're going to go on the next hill. What's the next big problem you're going to be tackling? which would be a market opportunity or an issue in scaling up the business. So I thought these were all very interesting tips. We had a session there during the workshops as, what's the best way to do a company partnership with a large organization there, what are the do's and don'ts. And I think both the lawyers and the entrepreneurs said it's really essential right from the beginning to ask for mutual NDA. And that will really set the expectation this is a two-way partnership as opposed to you trying to share all the information with a larger corporation. There are some issues there that was discussed, I think, at those meetings as well as Don's meeting on the board management about, there's lots of potential conflict of interest giving a large corporation a board seat. So one of the way to deal with that is maybe give them a board observer seat or information rights as opposed to have a fiduciary responsibility to represent whole shareholders, which is what typically happens when you have a board seat.
If I can chime in there for just a quick moment, Mike O'Donnell from Morrison Forrester on the workshop panel on board dynamics was explaining that he almost invariably can talk a strategic out of demanding a board seat from really talking through what the responsibilities are and how the individual would have personal liabilities for the startup company, and the startup company may have interests in conflict with the large partner who is their employer. And do they really want to put themselves into that position of having a legal responsibility to be, acting against the interest of the person that's employing them? And usually through those discussions are able to come to the conclusion that it's probably best not to actually have a formal board seat.
Yeah, no, that's very helpful. The other discussion we says, well, how do you manage a contract? And I think managing that negotiation there is really important, not only to get the best contract, but also to be successful afterwards in the implementation. We know that 80% of this partnership don't necessarily succeed. And I think that the advice of our panelists was very good, which is really discuss right from the beginning, really early on, what are the big issues. Don't wait for the last minute, a little surprise there just before you sign the contract. And some of these could be like, some like a marriage, if it doesn't work out, how do we unwind the contract so you don't accidentally kill the company? And also know where you want to end up with your board right from the beginning, so you know what are the things you will not negotiate on and what's the room that you can maneuver with, and have alternative. That doesn't mean you do a bidding war or an auction, but know that you're not depending on getting this at all costs, because the other partners will figure this out, and that may not be a balanced partnership. So I thought these were all kind of really good advice in my experience there, where people think that they first get the partners involved, and then you bring the tough negotiation later on, and you spend all your time getting there, and it blows up in your face at the last minute there, which is not always a good situation there for funding and for the morale of the troops. Don?
Oh, thank you. So one of the interesting things in this complex world of healthcare out there is just how do different systems kind of parse it up or view this complexity. And so I really found it quite interesting in seeing how Stanford Healthcare breaks it up into 4 strategic domains in their view of the world. So in these domains, there's really one is complex care, which is, you can see from the slide there, cancer, chronic care, multiple diseases. There's where there's really a lot of factors that are coming into that need to be dealt with. The other big one is reducing costs through better efficiencies in large medical groups, and so the sensitivity, really improving workflow. Then, of course, as we move towards more in the ACO model, that being able to demonstrate outcomes in improving care and outcomes in populations. And then one of the things that certainly has been an ongoing theme is that technology is an enabler. And so as they look at virtual care and other kinds of technology, they really see that as support of their other 3 goals there.
No, that's very useful, because that leads me to where I think it came up from several of the panels. At the end of the day, we have to keep in mind that healthcare is a service. And then you sell technology, what you're really selling is a technology-enabled care services. And I think it came across from several of the panels in both my prep calls and during the conference, is that right now technology is ahead of adoption. The issue is not pushing the limit of technology. The issue is making sure the existing technology we have are being adopted. And some of the issue there is the fragmented healthcare system, which is still there. I mean, we try to get integrated, but we're not there yet. There is clearly a payment misalignment. I mean, we've had situation with some of our portfolio companies there where if you go to a hospital system there where 80% of the revenue is still fee for services and you sell a value proposition that decreases readmission there, you are asking them to lose money. And that's kind of a hard sell. So it makes the ROI more complicated. There's still a lot of entrepreneurs are coming up not understanding the workflows. And I think one of our panelists recommended that you shadow existing physicians and nurses to understand where's the workflow, where does it fit. There's an assumption there that the data is flowing freely for all the different healthcare providers. That is not the case. We're trying to get there, but it's still not there. And that may impact the adoption of some of this technology if it requires massive user interfaces to the EMR and some other of these silo data systems. And at the end of the day, we still have the government there, where on the one side, they're giving grants to kind of enable this data flow. And on the other side, we have some significant regulatory roadblocks where there's regulation at the state level for what physicians and pharmacists can and cannot do. And there's regulation by the SEC and the FTC. I mean, there's a lot of issues there on not a full alignment at the federal level on what's the best way to get there.
So Ann, can I just ask you a quick question or to comment a moment on, there's the payment misalignment there between fee for service and value-based care. As long as an entrepreneur can demonstrate that or has a value proposition that they can take costs out, does that translate in that somebody's going to pay for that?
Yeah, I mean, the important part is that you have to get a value proposition that works in today's environment, which is still mostly fee for services. And if you can show that you can save money there under this environment, and as they're moving towards this risk alignment on value-based care, it's very important that your value proposition can change or is also working in that environment. And so I think it's important. I mean, it kind of makes the entrepreneur's challenge higher, is that you have to figure out if your value proposition is going to work in the fee for services, in a hybrid, which is fee for service and value-based care. Because, what I see some hospital doing, some large system, is that they deploy some of these applications only in the ACO hospitals, where they have a large ACO population there, but not into some other hospitals, which is still mostly fee for services. So you suddenly have your market there that's kind of a moving market. So I think it's really important that you design your business models, and you will figure out your business model as you go, but make sure that it will work under both systems in the transition period.
Thanks.
So how are the employers going to do this?
Yes, well, and a lot of employers are struggling with that question, exactly. And one of the interesting things that came out of this workshop was that ROI is absolutely important. I mean, we've all heard about, runaway healthcare costs, and employers have been bearing the brunt of that. But also the way that benefits interact with the corporate culture, and that the benefits that are being provided are really integral to how the company perceives itself and how they want to be perceived by their employees. And so that turns out to also be quite critical. And that's partly where impacts too, that there really, there's been some views that, employers just really want to get out of the healthcare business, and they want to convert it like what happened with pensions and 401ks, where they went from defined benefits to defined contributions. And really, that's not anything that's going to happen very soon. Healthcare is not the same as pension benefits. There's a lot of, in terms of, satisfaction at work, absenteeism. There's a lot of issues that are built in for businesses with their healthcare benefits beyond just the dollar side of it. So the dollars are critically important, but there's a lot of other factors there as well.
Was there any discussion about the Honeywell case, which is now being challenged in the court system, where Honeywell was charging an extra $2,000 per year to their employees if them or their family members were smoking? And then they were trying to force a test to see if they were smoking or not, which is, where it's like a penalty if you don't behave right, which I know several companies are trying to get to.
Well, so in my panel there was Safeway Health and also the Silicon Valley Employers Forum and Collective Health. There was a universal agreement that employers acting as Big Brother and focusing on penalties was really the absolute wrong way to go. That in terms of incentives, actually getting away from cash and using things like social support and peer pressure, group pressure is much more effective. If you have your entire work group is going out and exercising regularly and you're not, that tends to drag you along to go with them. That those kinds of behavioral things really are much more effective than, and particularly companies don't want to be in the policing or cop function. So at least on the panel of the group that I had, that was really a non-starter for them.
Okay. So we may have to speed up a little bit there to stay on the clock. So
let's move on to the next slide then.
So let's talk about how we're going to do that. One of the big area, of course, is the use of data. And I think one of my key takeaway from the ACO and the big data panel, as well as the provider panels, is that let's not talk about big data, let's talk about good data. And by good data, these are data that will allow you to do an action that is different and that is relevant to the environment at the time they get that information. The problem right now is 60 to 90% of the data is still unstructured. So the first problem that we're really focusing on right now is to search the data. And then one of the challenges is that the amount of data sources is exploding. You know, not only do you have the EMR and all the traditional medical data and the claims, but now you have all the quantified self and then the reporting data from the patient itself. So the industry is really trying to deal with, you know, what's the most effective way of really going from looking backwards, which is really what we're doing right now, which is, well, what happened 90 days ago, which is really more description of a history there. And therefore, it's really hard to change behavior at that time if it's about the past, to really where we want to go, which is looking forward. So I could find out down, you know, what are the things you're at risk for, so I can come to you and just, you know, try to get you to change behavior. And so right now, you know, a lot of the complaints we heard on the provider panel was the fact that at times the data they get is 90 days old. And so therefore it's really hard, you know, to change behavior. So that's one of the big area there. And so as a result of that, people felt that right now the big focus in these providers, which is also tied to this change of the payment system, is to really focus on let's improve the administration and let's improve the operations. Let's focus on efficiency. Let's focus on cost savings there. Because that one you can use all data to basically see, you know, what's the best practice, you know, what's the most effective way of doing things. There is the whole issue about, you know, the U data and the E data. How are we going to capture that? How do we analyze that? Because it's more qualitative data. There was an interesting discussion we had on the big data panel, which is, well, what does the patient want? What do they care about? Remember, we know as providers, we want data, we want science, we want something that's longitudinal, we want something that, you know, is repeatable and predictable. The data of the patient is really an N of one, me, am I normal? And in the context of am I not normal in my environment, what should I do about it? But ultimately, at the end of the day, the patient's need for data is very different than the need of data for the providers and the payers. And I think it was an interesting comment that came from John Madison from Kaiser, that really what we need to do with big data is what he called the inverted Big Bang. So we basically take all this information that's in the universe, bring it back to you. And as a result of that, drive personalized medicine. And, you know, he's very active in trying to drive this across the country there. So I thought this was some very interesting takeaway.
So in the telemedicine and really the healthcare anywhere panel, there's really a key message there that telemedicine has been around for a number of years, but it's really starting to take off now. I'll be jumping around the slide just a little bit here, but I mean, historically, there's been technology restrictions. The other thing is there's only been reimbursement in certain select areas from CMS. And what's really happened now is that there's such cost leverage and that people like it, that there's actually private reimbursement and private insurance. Usually it's the government reimburses first, and then private insurance companies come along to do reimbursement. And in telemedicine, that's really flipped on its head, where the reimbursement is much more prevalent in private insurance companies. So this is all really part of market forces that are going on out there. And the new developments, I think, are really indicative of where things are going. I mean, UCLA now is teamed up with Aetna so that all the UCLA docs can deliver care via telemedicine. Kaiser has announced that if you take the total scope of virtual interactions, that includes email and other virtual interactions, but they expect by the end of next year, they'll have more virtual interactions than they'll have face-to-face interactions with their members. And then the last thing, this is just kind of a side note, but I thought it was a really interesting one, and that is that in surveying telemedicine users, found that from the patient's perspective, they felt that a telemedicine encounter with their doctor was much more intimate than an in-person encounter, because you go into the doctor's office and there's a lot of pressure on the docs. So, you know, you're having a conversation and, you know, at the same time he or she's entering into the EMR and maybe getting, you know, preparing a syringe. And, you know, there's a whole multitasking that's going on. Whereas in the telemedicine environment, it's really much more of a one-to-one where the person is really focused and 100% engaged. And so that was an interesting benefit from the patient side.
No, that's very interesting. And so my top 3 now. And so this is for me what's the most interesting of the industry is that as we are having the risk being moved around there, it is driving a different type of business models for not only the providers, but also people selling to them. And this is what we talked a bit earlier there, which is that people really are asking for equity. I think UCSF said that they won't do a pilot without getting some equity there. And as I discussed in my keynote, you know, people are want an alignment with the value proposition that you're selling with your pricing. And we see that from people coming up with, I still try to sell my product there, but now you have to show the data that you can save money and the ROI, and then you can improve outcomes. And depending on what you're selling there, to really say, I want this at the subpopulation level or episode of care, like let's say a surgical event from pre-op to post-op, to the individual patient level. So it's an area we need to look at, because I think if this continues to happen there where everybody's passing the hot potato of the risk, and ultimately the hot potato will end up with the people selling to the providers as well as to the patients. So to be seen there, so be creative in your business models. And one of the things that came up in the star panels is that, you know, you can have a business plan there, but the only way you could figure it out is go out there, experiment, and learn as you go. So all these people who built very large company there, they were being very honest. They didn't have a business plan. They had no idea how it's going to work at the beginning. They just figured out, we'll go out there, make the customer happy, and then we'll monetize it. So top 2, Don.
Great, thank you. So, you know, a big issue is really the market, and you know, the healthcare costs really are with seniors. Technology reduces healthcare costs. Traditionally, seniors haven't been perceived as being the most facile with technologies, but really, Jody Holtzman from AARP is really pounding the table. He's got some new initiatives where they're really looking at the seniors market. And it was really clear that that should not be perceived as a barrier. And as the one example there that I've got listed is whereas 46 to 64 age group is 25% of the population, they represent 40% of all the technology purchases. So it's really key that to really view it more in terms of what they're calling life stage rather than age. So as Jody was pointing out, he's got 90-year-old parents, and they're online all the time. And then there's younger people who are, 60 years old that are, resistant to technology. So it really has a lot more to where the individuals are in terms of their views and their stage of life, rather than trying to segment based on age. Another really key point is that particularly when you get into wearable technologies, is it's really important that that this have good design. People don't want to be walking around with a badge that says, "Hey, I'm sick" or "I'm old." You want to have, seniors are like everybody else. They want to have, something that's really cool and part of the current world out there. And then the last thing I'll jump down to is really some of the what's coming as the bolus of baby boomers comes into this market and reshapes this market as it has other markets along the way. And it's really can be put in these terms that, as a baby boomer, I want what I need, when I need it, on my terms, and affordable. And these expectations are starting to be part of the drivers for changes in the healthcare system.
Okay. As we're going for top one, please, I start seeing some of the questions coming in there, so please, send them, then we're going to go over them. So my top one was that, this was something that was tweeted and it came out in a Wall Street Journal article, which is, really focus on application for sick patients, not necessarily the sickest, but the sick ones, and not necessarily the healthy one. I mean, and so the providers said, this is where we need the help, because if you're really healthy there, we're not really managing you on a daily basis. The key to success that they felt is that as you're coming up with new application, is somehow we have to come up with something that helps us integrate data that is shareable and actionable. So, keep that in mind, that it's really hard to have a standalone product nowadays that is not somehow integrated into this new data flow that's flowing around. It has to fit with the clinicians' workflows. The clinicians are still involved because you're talking about sick patients there. And I think you need analytics that are configurable. The one experience I've had over the last 30 years selling to hospitals there is that every hospital wants something that's adjustable to their needs, and then very often the patients want the same thing as well as the physicians there. So they talked about self-service analytics and the capability for people to analyze the data there. There was something that was a bit more concerning, which is as these hospitals are integrating and consolidating, they want a solution that's scalable. So when they see a company coming up with a new solution, then one of the area they're always concerned about is that, is this going to be scalable? If I deploy this to 100,000 patients there, can you hold it? Can you implement that? And I think the entrepreneur needs to start focusing in validating the strengths of their backend and the capability of scaling up if they want to start getting some of these first big contracts. In the short term, people again reemphasize the fact that they really need way to streamline collaboration within their hospital settings, within the clinical settings there, and as we're moving towards care anywhere, the ability for them to communicate with a health coach, a family, a patient, a different caregiver. And the data has to become more transparent. I mean, what has created a revolution in consumer in the past is the data transparency, and we're clearly moving in that direction there. We really appreciate everybody's input there. Nick, do you have any last words about Zoom and how great you were?
Thank you. You guys are great. What a great session. I mean, lots been said and lots to learn. And you guys did a great job in covering big aspects of this. Thank you. With that, I'll let you guys close out. And for those that have attended or would like some more information, we will be providing this recording back to Ann and Don, and they will be sending you guys a note with the link as well. And as usual, they are reachable for any sort of contacts, and their emails are on there as well. Feel free to reach out. Again, we do appreciate all the time that you guys been with us today. And again, for Ann and Don, great perspective, and thank you.
Thank you.
And thank you for everybody who attended.